Hello students, today we are going to talk about reconstructing the normal joint anatomy. In our previous talks, we have presented every joint can be represented by a movement mechanism. If only everybody will have the standard joint geometry. In reality, everybody is different. We have a lot of anatomic differences, so a simple representation of the mechanism does not answer all the question, and anatomic restoration of each joint geometry is important for every patient. So in this point, the modern arthroplasty or joint replacement are always looking into restoration of normal anatomy, and that can be impacted by two different sources. One is the design of the implants, and the second one is actually the surgical management. How do we perform the surgery? We are going to use total knee design as an example of seeing how design philosophy can affect the reconstruction of the joint anatomy. So first question we're asking, why implant fit matters? Can't we use one size of the implant to fit all the patients? Well, the reason is that we have been from previous clinical data shown implant overhand can cause soft tissue impingement, inflammation, and pain. For example, on this slide, 3 studies talking about how 2 to 4 millimeter of overhand can significantly impact clinical important pain after surgery, lower Oxford knee score, lower outcomes, and also higher MCL loading. So from biomechanics standpoint, also adding more stress on the MCL or soft tissue. So overhand, excessive overhand is not a good thing for the clinical outcome. Therefore, for our implant design standpoint, we want to avoid overhand. But on the other hand, can't we just use a very small implant so that we do not have any overhand? But then we'll have underhand. That will also, in theory, cause loosening and subsidence of the component, as these studies have talked about. Once we have insufficient coverage of the bony resection surface by the implant, you can certainly think about the implant will put a lot of stress on limited areas. Those stress-raised areas would cause subsidence and loosening fixation problem for the surgery. So we do not want excessive underhand as well. While we understand how important implant fit is, but the question itself, the problem itself we want to solve is very complicated as well. As Dr. Mahfouz showed in this core study in 2012, if we look at different ethnicities and male and females, these F and M's are male and female and males, and we have American, we have Caucasian, we have Asian. Just ignore all these markers, but between genders and ethnicities, we have a lot of different types or shapes and sizes in our knee. And if you look at some of the Middle Eastern data, they are presented here. These are the range we're looking at for a single measurement for a certain dimension. So we have a range of data to manage, a range of size and shape to manage. We have difference between ethnicity and genders. How do we use implant design to represent, to sufficiently capture this such that we can achieve clinical outcomes that's good enough? Well, or if we look at the question, for now, our design is actually trying to represent the continuous morphological expression in population. Seeing if you look at any of these measurements here, these metrics describe morphology here, they are actually a distribution over a range of sizes and shapes among the population. But we are not going to be using an average to fit all. So you cannot design implant just by the average data. You're missing pretty much the lower half and the upper half, such that the current philosophy of implant design is to sample the distribution curve and come up with a series of sizes and use this discrete design variables for each size under a design philosophy to be able to fit the population. So we want to make sure one size can fit the most of patients among that range, close to that range. But also, we have seen that simplicity is the ultimate sophistication. And how do we make sure we can have a best design philosophy that's simple enough but sufficient enough to make sure we have a good implant fit? From the total knee arthroplasty standpoint, in terms of distal femoral morphology, this is the plot correlating the anterior-posterior dimension and mediolateral dimension of the distal femur. And as you can see across Asian, African American, and Caucasian, across genders, we have some trends. This is not the only study. A lot of studies have shown that Asian knees are generally smaller but wider than Caucasian knees, and female knees are generally smaller and narrower than male knees. In terms of femoral design philosophies, there are actually 3 in the market right now, with 2 of them captured in off-the-shelf designs. And as we mentioned in the previous slide, AP and ML dimensions, the benchmark the size and shape of the distal femur related to femoral design. And we always use one critical metric, that's the ratio between AP and ML dimensions, called aspect ratio. Then for the 2 off-the-shelf philosophies, the classic one, which has been used to be in earlier designs a standard, that's 1 aspect ratio per AP size. So that means you have, for example, 8 sizes of femur, you have 8 AP sizes, and each component will have a 1 single AP size, and also you only have 1 ml size to go with it. So 1 shape per AP size versus multiple aspect ratio size. That means famously we all know about standard and narrow design. That's a perfect example. For the same AP size, you have 2 components in this case, each will have a different ml. And of course, personalized AP aspect ratio, that will be one of the solution as well, although high cost, but that will probably guarantee a very good restoration of the native aspect ratio. And one thing else about why we're having 2 aspect ratios, the consideration would be a better fit between narrow and standard knees, and also it comes with for narrow device, a narrow component, it comes with a narrow flange as well. So it's also addressing not just standard narrow at the distal femur, the distal cut, but also standard narrow at the flange area. And we have been showing how these multi-aspect ratio designs can improve the fit, the anatomic restoration of the distal femur. This particular study, actually open source study, I do not have the device names in there for a unbiased review, but welcome to check out this particular paper that compares designs A and B, which had multiple aspect ratios, to designs C, D, E, and F, which only offered 1 aspect ratio. And as you can see in the right image, it is actually a measurement of percentage of bones. We have a few hundred bones covering Asian and Caucasian, also both genders. From the few hundred bones, how many percentage bones are falling in each of these categories. The x-axis actually showed the fit of the implant. It's a patient-specific implant placement, and negative values means the placed implant actually had underhand, and positive value indicates overhang of the implant. And as you can see, a very minimum percentage of bones using designs A and B, the multi-aspect ratio designs, actually fell in a over 3 millimeter overhang. So very, very minimum risk of overhang, clinical significant overhang. Compared to the other 4 designs, significantly higher incidence of overhanging beyond 3 millimeters. So this demonstrates how multiple aspect ratio can help improve anatomic fit of the distal femur. Well, there's another design factor that's on the femoral component. That's the orientation of the flange. And currently we have a couple design philosophies as well. We have lateralized flange. We have lateralized with a distal S-curve, so it's in general lateralized, but it's actually having a S-shaped curve or tracking on the flange. And we also have for just one design family a neutral tracking, so the average tracking is neutral, but with a widened proximal part such that your patella can track at a range of angles, and finally with high flexion converge into the notch. So all these designs are, as I mentioned, impacting patella, patellofemoral tracking. But to understand these designs, we first look at what is the native tracking angle in the distal femur. And from a couple of papers, we've actually found the average tracking angle is about 1 degree, or basically neutral, but with a very wide standard deviation. That means you have about plus minus 10 degrees of possible tracking angle. So on average, in one sentence, on average, a neutral tracking, but the actual, in reality, every bone has a varying degree of tracking that's up to plus minus 10 degrees if you're talking about 95% of range of all the angles we see in the population. So these are very interesting results. But if we compare that result to what we have in the field right now, we have this one design that's actually tracking a neutral, but allowing an angle, a range of angle that seems to be really matching the native femur. And we have all these other lateralized idea, different level of lateralization. That is, as you see, may not match the native femur own tracking or flange geometry. However, both designs are doing well. Both of these design philosophies are doing well in reality from the clinical outcome standpoint. So design A is more about representing the native femur flange geometry, but the other 4 designs are based off the Q angle, which is why they are lateralized. So they are more focused on the macro level expressed patellar tracking angle. But as I said, both of them, the philosophies are getting very good clinical outcomes. On the tibial side, it's a kind of bean shape. It's much less complex geometry in terms of the resection itself. It's only one cut, so we are dealing with pretty much a 2D contour of the resection. And also, people are always talking about gender and ethnic differences. That's why this particular paper took an approach to comprehensively assess the gender and ethnic difference between male, female, between Asian, Caucasian, how those factors are impacting a lot of measurements, either dimensional, size, shape of the tibial resection contour. And actually, the conclusion is gender and ethnic differences found were all in size, not so much in shape. So a male tibial resection is simply bigger than a female, but not very drastically different in terms of the shape. And particularly from the study, there are some new measurements introduced, especially the anterior radius, which is the radius of the medial and lateral anterior corner. And that actually is one of the key radius or key metrics, a new anatomic design, maybe not that new, but a very good anatomic design, the Persona Zimmer design was focusing on. And we found that actually the actual radius changes, and it's between 1.6 and 1.9. In that same study, a example was presented based on using statistical shape analysis to assess the variation of tibial resection contour, the size and shape of it within the target population. And the finding pointed out that the overall proximal tibial size, that is the driving most of the variability we see in the population. That's reflected in PC1, the most important factor to drive the variation. Not so much about the math, but it is a very nice example of how actually several designs are using this method to help understand and assist development of anatomic implants for better restoration of the patient anatomy. So if you're interested in more math, I would encourage you into reading this paper, the same paper as the previous slide. So from that comprehensive analysis, design of the anatomic device can be made that comes to this Persona design that based off all these hundreds of overlapped resection shapes, the shape of the tibial trays then are developed, nine sizes of them to capture all these anatomic variations. And paper has actually compared the coverage, how the tray cover the resection surface, and it's significantly higher than the other leading designs in the market. One other thing about anatomic design is in addition to providing more coverage, it may potentially also resolve some of the conflicts or compromises we have been seeing in the classic designs or symmetric designs. For example, here when we look at a surgeon, if he or she wants to maximize fixation or maximize the coverage of the implants, he or she will have to internally rotate the tibial tray to be able to upsize and achieve the maximum coverage. For example, design C, D, E, F, and design B, you can see that you can use a better coverage, a larger size of the tray, only if you internally rotate the placement. But on the other hand, we know internal rotation of the tibial tray may result in abnormal kinematics, wear of the excessive wear, and essentially leading to worse clinical outcomes. So that's actually more important, more critical than achieving a few percentage more of coverage. So in reality, the surgeon would have to compromise and use a smaller tray, but really make sure it's properly aligned. With anatomic design, actually maximizing coverage does not conflict with correct alignment, as we mentioned in a couple of slides ahead previously. A understanding of the anterior radius of the tibial resection, which means by properly designing that anterior radius on the medial lateral side, you can see on design A how it's properly placed regarding to the rotational axis, yet also properly sized to provide a better coverage. And on the right, you can see a summary of how, on the larger scope, based on this several hundred patient data, CT-based surfaces, CT-based placement, percentage bones that's actually requiring internal rotation to achieve the maximum size possible is much lower with design A compared to the other designs. And also, if you look at the downsides or the compromises the surgeon has to choose for ensuring correct alignment, which means, for example, design E, on that figure you have, if you want to maximize the size, that's going to be a size 3, but in reality you will have to settle or compromise with size 1 with correct alignment, so that's a 2 size downsize. So the figure actually showed that the percentage of bones that actually will have to be downsized to make that compromise is very minimum in design A compared to the other designs. So that's the advantage of once we properly understand the morphology of the bony resection, there's opportunity for us to design the implants to minimize the compromises, the conflicts we have between different surgical goals. From the patella standpoint, we have patella design, anatomic patella design available right now. So for patella, we're talking about articular surface and a ML ridge. So for a good implant fit, you want to cover as much as possible the resection surface to reproduce the articulation with good fixation. And you may want to restore the ridge position as well, because that will directly impact your ML positioning of your patella button compared to the femur. And for example, here with this attuned design, it has been shown in multiple studies that it's not only increasing the coverage, but it's also restoring the peak of the dome or the ridge position. So that's the beauty of the anatomic design for patella. Well, we talk about anatomic design for femoral. That's through multiple aspect ratio. We've talked about tibia, that's through statistical shape modeling of the population. And for the patella, that's through the same kind of shape analysis, understanding of the morphology for patella button. The next category is the impact of surgical management on reconstructing anatomy. And there are multiple surgical factors that can impact your anatomic restoration. Surgical philosophy and approach, choice of anatomic references, impact of resection variability, and management between multiple anatomies, not just one bone, but take the joint as a whole structure and managing the relationship between them. And from those sources, the impact implant fit regarding the restoration of individual bone anatomy, and also impact systematic fit, that's the restoration of a structural anatomy. From surgical approach standpoint, for example, regarding distal femoral preparation, if we're using anterior referencing versus posterior referencing, we can clearly see we may either change the posterior offset or cause anterior notching or patellofemoral either understuffing or overstuffing. But depending on which approach we choose, it may very well impact the sagittal anatomic restoration of the distal femur. From surgical reference standpoint, we have the mainstream concept right now, mechanical alignment. That means our bony cuts should be perpendicular to mechanical axis, while we'll also have the kinematic alignment, the new school of thought. Depending on which philosophy we're using, our resultant resection surface may have different size and shape. And because almost all the implant systems in the market right now are designed based on mechanical alignment resection, then with the kinematic alignment resection, we may expect anatomic fit being alternated, not as the same as the based on the mechanical alignment scenario. From the rotational alignment standpoint, a lot of devices, anatomic devices, can be designed based on certain assumption of AP axis or i.e. rotational axis. For example, medial third tubercle to PCL attachment. If everything is tightly designed around this anatomy, it will fit really well, but given that some surgeons may use a different definition of AP axis. In that sense, if we put this very well designed anatomic implants around a particular AP axis on this different reference frame, we may also expect to have an anatomic fit alternated. And a lot of you will use mechanical instrumentation for surgery. That means a reamer to establish femoral anatomic axis for your femoral alignment. And we are always assuming about 6 degrees of offset to be able to restore that alignment back to femoral mechanical axis. But this is the average value. In reality, there is some sort of range around this, especially when you have severe deformation or different degrees of deformation. So that will change this actual offset, which we do not know unless we have navigation system. Then in this case, that will result in different alignment cut that also will change the width of the cut and also the fit of the cut. Anatomic fit may be altered as well, alternated as well. And for all these manual surgeries, human error is unavoidable. Some good surgeons will do a very good job, but still with some error, small but minor, but some error. We cannot guarantee, and we should not guarantee, everybody will produce perfect cut with ideal alignment and minimum bone resection. If we shoot for a 3 mm resection, or 5 mm will be right on, not more, not less. That's a unrealistic assumption. So in reality, we will have some degrees of error in alignment, and we may take more bone than we need to, or less, either way. But these will change the cross-section, the actual resection cross-section, and also impact anatomic restoration. And those are management of the single bone. And if we talk about the whole joint, that's a structure. For example, management of the patella button compared to femoral and tibia. And basically, if we restore the patella button and the femoral and tibia back to ideal location, we'll have a pretty natural tracking. But it's not guaranteed. It's determined on how we put the button on the patella button design as well. So that may change the tracking and also the placement of the femoral. So you have the interaction between the button and the femoral, and depending on the design, depending on overhand, underhand placement, that can change the tracking after the surgery. So this cross management between multiple bones, a surgeon would have to evaluate and cross manage them. So that's just one example, but another very common example is how do we restore the alignment of the knee, and that's considering both femur and tibia at the same time in terms of restoration to neutral alignment. So that takes a cross management of the anatomic restoration. There are tools that's available for us to help us to better manage anatomic restoration. For sure, our surgeons, they have their own preference for surgical philosophy and approach. They have their preference of choice of anatomic references, but we can use advanced surgical technology, advanced tools to help them to make sure minimize error in terms of resection variability and help them to manage between multiple anatomies. So that's the benefit of navigation and robotics. With that, today we talk about how implant design philosophy could address your needs for anatomic restoration, and also keep in mind that multiple sources exist from the surgical management standpoint that may lead to surprises or unwanted alternation of the anatomic reconstruction, and tools that may help us to manage that situation. With that, this is the end of the lecture. Thank you.